once again, Dr. Rahul, and again we are coming to orbit. So, topic is congestive orbital venopathy, and I'm discussing a case of indirect CCF, which have a lot of congestion in the orbit. So, 40-year male, chemosis in the left eye, no diplopia, no restriction of eye movements, no breathe. So patient was roaming from one ophthalmologist to other ophthalmologist because there was no proptosis actually, only the presentation was chemosis. Luckily this patient went to one neurosurgeon who actually first seen when a patient has a mild head injury 5 months back. So where the neurosurgeon thought that possibly it can be some of the vascular malformation in eye, because otherwise patient had only congestion of the eye. CT scan and MRI both was normal. The CT angio shows some prominent ophthalmic vein. I don't have CT angio at this moment. So CT angio also has prominence of ophthalmic vein, and that's why this was suspected. So these are the DSC images, and this is the external carotid artery injection, and we can say this is a middle meningeal artery. This is the cavernous sinus, which is filling. This is the superior ophthalmic vein. So it is the external carotid artery injection, and we can see there is a middle meningeal artery, and it is directly connecting to the cavernous sinus. It is a superior ophthalmic vein, inferior ophthalmic vein, angular vein, and there are a lot of facial veins. There is a close view, and we can see this is the middle meningeal artery. There is a fistulous connection between the middle meningeal artery and the cavernous sinus. Superior ophthalmic artery, inferior ophthalmic artery, these are the angular arteries, and these are the facial veins. This is the AP view, and we have connection between the two veins from the right and left side also. This is the internal carotid injection on the left side, and it does not show any connection with the cavernous sinus, so there was not direct connection between the internal carotid artery and cavernous sinus. Only there was an indirect connection, so what we call a type C type of CCF. This is the microcatheter exactly at the fistulous connection, and then the glue was injected. This is the glue cast here, and this is the post-embolization. We can see there is no filling of the fistula at all. This is on the left side, and we can see the glue cast here. So this is the post-embolization. After 3 months, we can see the eye become absolutely normal now. So basically, it has superior ophthalmic vein, which is basically give branches to the facial and the supraorbital veins. This is the inferior ophthalmic vein, which is the source for the venous plexus for the floor of the orbit. So these venous channels become prominent when there is a retrograde flow, when there is a fistulous connection. This is the video of the case. So this is the injection. So this is the ophthalmic vein. Yeah. Cavernous sinus and superior inferior ophthalmic veins. This is the fistulous connection. This is the AP view, 3D. Now this is the microcatheter injection, microcatheter in the fistulous junction, and there is the post-embolization. And then fistula is completely gone. And this is the glue cast. The another case, only 2-3 slides are there. So this is a 17-year male, head injury, and we can see marked venous congestion, and in eye you can see all veins are very much dilated. This is the external carotid artery injection, and we can see from the middle meningeal artery, there is a filling of the vein. But again, this filling is limited up to here only. So there's not much filling to the superior ophthalmic vein or inferior ophthalmic vein. There's just filling of the vein. Possibly this part is thrombosed. So what to do? Do embolize in this case or not? Because vein are filling up to here, and again there is no filling of the superior or inferior ophthalmic vein. I was not very sure what to do because vein are filling up to here, and that's all. And yeah, there is no filling from the ICA. So I was not very sure to embolize or not because although there was a marked congestion in the eyes, so I did not embolize this case. I just put the patient empirically on anticoagulant only, possibly because of there was a thrombosis of vein, and patient done well. Even with the anticoagulant, I've given anticoagulant for 4 to 6 weeks, and then this congestion subsided. So basically, these are the case of the indirect CCF or type C fistula, where we have the direct connection from the external carotid artery branches to the cavernous sinus. Often these patients do not demonstrate classical triad of symptoms, so they are difficult to diagnose because there is no proptosis or no bruise there. Usually only they present with the chemosis. So they are difficult to diagnose. And these are thanks to my colleague Dr. Gandhi, Dr. Navneet, and Dr. Rahul.
Excellent cases, sir. So any questions, any discussions?
Do you have the same protocol for the ECA 3D angio also as for the ICA? Like the same pressure, the same amount of dye?
Yeah.
So the ECA 3D is also like the ICA 3D that you acquire?
Exactly.
Okay. And did you have a post anticoagulation angio to see what has actually happened to that segment? Because whether the anticoagulation has worked, and if it has worked, in what way?
Yeah, clinically subsided, but we don't have post check angio. We don't have post check angio. Yeah.
Possible. Quite possible. Quite possible.
Yeah,
maybe,
possibly.
Maybe some infection, maybe some inflammation.
Yeah, there is some thrombosed vein. Yeah, there was no fistula basically. There is a connection between external and internal system, but it was not filling antegradally to more.
Devashish.
Also, in the first case, the fistula, because it was there, probably the eyeball, like orbit, was not draining back into the sinus. So, if you put glue and occlude those veins, also, won't the congestion still remain there?
Why? The fistula is completely occluded, so why there is congestion?
Even the draining veins are also blocked now, no?
No, draining veins are not blocked. No. Only the fistulous connection has blocked. Not the draining. The glue was not there in the superior inferior ophthalmic vein. It was just in the fistula only.
See, basically what happens is when the ophthalmic veins are arterialized, the arterial pressure is reflected onto the entire globe. So superior ophthalmic vein and inferior ophthalmic vein are just the ones that you see. There are many more tiny venous channels that you don't see. So the moment you stop the arterialization of the remaining veins, not superior and inferior ophthalmic, because in most cases of CCF, we try and penetrate. So for example, if you come via the superior ophthalmic vein, then you coil it up to the point where the superior ophthalmic vein gets almost completely thrombosed, completely closed. But what this does is, this does not allow the arterial pressure to be reflected into the remaining veins of the globe. So that is how the hydrostatic pressure comes down and the eye starts draining via some other pathways. You have taken out, let's say, the superior ophthalmic vein, you have the inferior ophthalmic vein, you have the lateral ophthalmic vein, and you have many tiny transosseous veins. which are draining that entire area. So obviously those will take care.
Sir, the first case that you say, yes, sir.
Kaushik.
Yeah, yeah.
Sir, the first case and the second case, I mean, at least the first case was an indirect CCF, no, sir?
Yeah, it is indirect CCF. Yeah,
Sir,
type
when
C.
we look into literature, that is one indication where they talk about venous access being the more preferred access than the arterial access, no, sir? Why did you choose an arterial access
It
for this?
was very easy. Artery access was in this very easy. There's a very prominent middle meningeal artery, and I took just coiling catheter in this case. So it was very simple rather.
Because,
it took hardly 15 minutes to reach through the arterial return. I think venous route was more difficult in this case rather than arterial, for me at least.
See, this was not a typical type C fistula. This was not even a typical CC fistula. Because if you see the runs, the cavernous sinus connection, that posterior-most part that you were saying, that you were seeing there, it is quite possible that it was the anterior compartment of the cavernous sinus, but that anterior compartment was not communicating with the posterior compartment of the cavernous sinus,
exactly,
because there was no flow which was going posteriorly.
Yeah.
So it is also quite likely that you had the variation where the superior and the inferior ophthalmic veins were joining and forming a common trunk, and this was a fistula right at that trunk, post-traumatic. It is quite likely. So if we do a cone beam, we will probably see the rent there. So again, it might have been a direct CC fistula, it might have been a middle meningeal to ophthalmic common collector fistula, because the flow was very high. So flow was not looking like a typical indirect CC fistula which we see.
And even from what I understand in the indirect CC fistula, no, sir, the draining veins from the CC are so small and multiple in number. We couldn't see that kind of an a morphology
so
also.
This was atypical. This was fairly atypical, yes.
Yeah.
Any more questions?
Even by going with the venous route, it's very costly. So you'll have to have a balloon, make a pressure cooker. Onyx, again, the amount of onyx that you'll use in venous route increases. So like the cost goes very high. So if I've given an option arterial versus venous, I'll first try arterial because the cost is almost double when you like go for venous. Like balloon costs you a bomb, then onyx, everything.
Agreed, but most of the time in this indirect CCF, they use a short sheath and they just go through the inferior petrosal and just put coils. They don't use liquid embolics in most of the cases.
If you have a very good inferior petrosal, you can do that.
We usually, meaning what I understand is that.
Yeah, you can do that. But very often the inferior petrosal is thrombosed, then you have to drill it, then you have to take the reverse end of a wire, poke it. So if you have a good arterial access, why not?
Even in the direct CCF, I still like arterial route first rather than venous route. Of course, there's a lot of people who prefer venous route in direct CCF, but still I think arterial route is still easy.
Direct, it's okay, sir, meaning, but in one of the conditions where we read in literature about CCF, or for that matter, dural fistulas, where venous route is first recommended, is usually comes under the...
Yeah, I mean, as long as you take the fistula and you take down the vein, what difference it makes? Fine. So I think with that we reach the end of this course. Thank you all for coming and making this program a success. And in the next version of the course, thank you. In the next version of the course, right now I can tell you it will happen next year approximately at the same time. And this time we will be talking about mainly the CV junction and the posterior fossa. So the entire focus of the discussion in the next meeting is going to be on the extension of the spinal cord. That is the CV junction, the vascularization of the CV junction, vascularization of the posterior fossa, and all possible pathologies of the posterior fossa. All posterior vascular pathologies of the posterior fossa. Thank you all.